Alright, so let's talk about something called prodrugs. This is an interesting concept in chemistry and pharmacology. But what is a prodrug? Well, it's a pharmacologically inert or inactive substance or drug that is biologically activated in the body or in vivo. So it's metabolized by the body into the active form. So why do we make prodrugs? Why don't we just administer medications like how they come? Why do we use co-salts? So I'm going to dive into that. One reason is poor aqueous solubility. So it's not very soluble in water. So to make a drug more soluble, we'll add a co-salt onto it. So one example is solumedrol or methylprednisolone sodium succinate. This is a steroid that we inject intramuscularly. So here we have the inactive succinic acid derivative of methylprednisolone, and we have that little ionizable group that cleaves off in vivo in the body via esterases into the active form. So again, we add these ionizable groups to increase aqueous solubility. And another reason is poor taste. Some drugs just taste terrible. So what we do is we make it less soluble so it doesn't interact with taste receptors. So one example is clindamycin palmitate oral solution. So clindamycin is an antibiotic that covers gram-positive organisms. We call it the above the diaphragm mouth and gut anaerobes. So it's often used in patients who are allergic to penicillin, prescribed by dentists, and then it's also for other things like BV and vaginitis, as well as some abscesses too. So here we have clindamycin palmitate with this long chain with poor water solubility, and it's cleaved into clindamycin by esterases in the gut wall and the plasma. A third reason we make prodrugs is pain at the site of injection. So when a drug precipitates or comes out of solution, it can cause tissue damage. So you want to increase the solubility in the solvent. One example is clindamycin phosphate. Another example is fosphenytoin. So phenytoin or dilantin is a medication that we use for seizures. We can see that we formulated a prodrug with a phosphate group, and then it gets metabolized by phosphatases in the body. So what are phosphatases? They're enzymes that cleave off phosphate groups. And then my other two examples with the esterases are enzymes that cleave off esters. So this is a concept that we learned in organic chemistry. So over here we have a carbon between two heteroatoms is what we call it. It's a mass carbonyl, and it undergoes spontaneous collapse into phenytoin, which is the active form, with a byproduct called formate. Another example is phosphopropofol or Lucedra. This was approved in 2008. It was a controlled substance Schedule 4, which I thought was interesting since propofol is not a controlled substance. But propofol is an anesthetic that we use for surgeries and in the ICU. It comes as a lipid emulsion because of its poor aqueous solubility. So the lipid emulsion is made with soybean oil, and then it can also increase a patient's lipids if they're getting a lot of it. And then it also poses a risk for bacterial growth. So what we usually do is we add like an antimicrobial to it or something like EDTA. So it causes pain with injection. So what we did was we added a phosphate group, which increased the aqueous solubility so we didn't have to make a lipid emulsion out of it. And then it also decreased the pain with injection. It was a prodrug that metabolized into propofol, as well as some other metabolites. It was a good idea in theory, but phosphopropofol or Lucedra didn't really make it on the market for too long before it was discontinued. This was due to its delayed onset. It took about 4 to 8 minutes to cause sedation versus less than a minute or about like 40 seconds with propofol. It also had a slower recovery time for patients coming off of it. And then it also caused some paresthesias, which is like numbness and tingling, and then some pruritus, which is itching.